Hello, everyone. I am Dr. Ferrer from Cairo University Hospital in Barcelona, Spain. I'm going to discuss about early diagnosis of sepsis. Those are my conflicts of interest. You know that sepsis is a global health priority around before COVID. More than 30 million people die or develop sepsis per year, and more than 5 million die because of sepsis in the world every year. And that's why the World Health Organization consider that that sepsis is a global health priority, and in fact approve a resolution aiming to improve prevention, diagnosis, and treatment of sepsis. And I think this is a challenge for our and next generation to reduce the mortality of sepsis. And for that, sure, new treatments are coming, sure, new advances in different phenotypes for sepsis will come. But the first step for applying better these treatments is sepsis early recognition, because at least in the Surveillance Sepsis Campaign guidelines and bundles, we know that sepsis is time dependent, that sepsis is a medical emergency, and those treatment listed here should be applied or should be started at least during the first hour after sepsis recognition. However, if we are not able to recognize sepsis early, all of these therapies will arrive late. Diagnosis and treatment will arrive late, and mortality is going to be higher. So we have, if you want to reduce the mortality of sepsis, we have to organize our hospital, our departments, to improve sepsis recognition. In fact, in my hospital, we have this sepsis code. In this case, we call it sepsis code experience, that we try to organize all the steps in sepsis care, and specifically during the first 30-60 minutes, we have to put together patient evaluation together with the biochemistry lab, the micro lab, the radiological areas to improve or to achieve good time to sepsis recognition. And this is important because then we can reduce time to adequate therapy and try to reduce mortality. So it's very related in how we are organized, and codes, I think, is a good way to organize. So we need to recognize sepsis. So we have to understand that sepsis is organ dysfunction caused by a deregulated host response to infection. So we have infection, and we have a host that, because of a deregulated immune response, generate organ failure. So we have to recognize both infection and organ failure. And in my opinion, infection is much more difficult to identify than organ failure. So diagnosing sepsis means that we need to identify those patients with infection. As I said, this is the most difficult part, and then try to see if the patient is having organ dysfunction. In the last definition of sepsis, the panelists define organ dysfunction as an increase in 2 points or more of the SOFA scale for the different organs represented in this slide. So we can use scores for that. In fact, the panelists define the Q-SOFA for identifying patients that have infection and that are at risk of having sepsis. And as you can see here, they selected the Q-SOFA because for them is the best score for taking into account the ROC curve for identifying patients outside of the ICU. However, the problem is that the sensitivity from the beginning, because this is coming from the publication of Mervyn Singer, from the beginning, the sensitivity for mortality, for severity, really it's low. And that's why many other key opinion leaders or investigators are preferring to use SIS criteria because have more sensitivity than QSOFA. In fact, several studies have shown that the area under the curve is not so consistent with the data shown by Singer and co-workers, and other investigators show that the area under the curve could be higher for other scores like NEWS and MEWS than for QSOFA. So QSOFA is a little bit under discussion, and if you want higher sensitivity, probably the old SIS criteria are better. The accuracy and the timeless for early warning scores is high, and maybe the highest can be achieved with computer run algorithms, but this is again not very feasible in many hospitals. So my message here is that scores can be helpful, but of course they're not so reliable, and probably early warning scores that are implemented in many hospitals around the world could be now the best option, even better than QSOFA. So for diagnosis infections, we need a complete workout of review of the patient history, a complete clinical evaluation, and a target imaging according the patient's signs and symptoms. And this is again very important, and we have to establish which is the syndrome in patients with sepsis we are facing. It's a pulmonary, abdominal, UTI, catheter, neuro, or other, like skin and bones, which is the source of this infection. This is important because most of the antibiotic guidelines will recommend a treatment according the different source of infection. This is quite important. So this is part of our diagnostic workout, not only identify organ dysfunction, also try to identify which is the source of infection, and of course, if we are not able to identify the source of infection, the probability that alternative diagnosis is there, it's also should be considered. When we have identified which is the source of this sepsis, we have to choose the adequate antibiotic, but also in many cases we have to establish a source control technique for controlling the source of infection. Microbiological lab is playing a very important role nowadays. We have the traditional blood culture, but you know that the time to results could be very long. In some cases, it takes days, and the new molecular techniques can reduce this time to results. This is a new challenge for clinicians, because that means that or several studies have shown that only providing early results do not change clinical practice and do not change outcome. If you see here the studies assessing the role of rapid diagnostic test in mortality in different studies, you can see that the positive effect is concentrated in those studies that incorporate, together with rapid diagnostic techniques, antimicrobial stewardship. That means experts at bedside that take the results, interpret the results, and change the treatment enough to change mortality. So again, the pathway, the way we organize care in hospitals and departments, it's very important. It's very important. So we have all our clinical workout together with image, together with microbiological test, but we need the experts that react when we have a result coming from the lab, especially if we have rapid diagnostic test, that the result can be released, for example, in the afternoon or in night. Another important tool we have for early diagnosis of sepsis are biomarkers. However, biomarkers are not the holy grail. Here, I show you this review we have written a couple of years ago with my colleagues Torres and Artigas, showing that for different conditions like CAP, BAP, and sepsis, we have a lot of limitations with biomarkers. And in fact, the most used biomarker like procalcitonin is being used more for antimicrobial de-escalation than for sepsis identification. So we have some limitations. Why we have some limitations? Because we have to use better, probably, the biomarkers, and because we need better biomarkers. Here you have the typical situation when we use a biomarker. If your patient have a very high pretest probability of having an infection or having sepsis, probably the test is not adding value because you are convinced before the test that the patient has sepsis. And in this case, you have to treat your patient. In those patients that have very low probability of having sepsis, probability the test is not going to change your previous diagnosis, as it's not going to add value. It's only when you have uncertainty, the patients have some degree of systemic inflammation maybe, then is where the test can be very useful to rule in or rule out sepsis. If the patient, if the biomarker is helping to understand that this patient has sepsis, then we have to start antibiotic as soon as possible. If the biomarker is negative, probably you are ruling out sepsis and you can think in an alternative diagnosis. So if the biomarker is a good biomarker and we use the biomarker in this way, this is quite ideal. The problem is that with procalcitonin, CRP, etc., this persists some uncertainty after using the biomarker. So, so this is the ideal situation I mentioned to you. We are in uncertainty. If the biomarker is able to, after the test, reduce the uncertainty, then we are ruling out the infection, we are ruling out sepsis, and we have to start treatment. If the biomarker is able to rule out sepsis, we have to think in alternative diagnostics. But if we keep in situation of uncertainty, we have to keep testing, because we cannot establish the diagnosis of sepsis. So we have to improve the way we use biomarkers, but also we have to improve the biomarkers we have. This is an example, CRP in patients the postoperative period, trying to find if the patient have a secondary infection. Oh, this is a typical model of two hits, when we have one hit, which is surgery, and a second hit that could be infection. And really for ruling in or ruling out sepsis in this scenario, you can see here after day 3 that the 3 curves, the patients with no infection, the patients infected, and the patients infected before the surgery, and the patients infected after the surgery, is really complex to identify which patients, according to the biomarker, are in one of these 3 situations. So, which is the cutoff for ruling in, ruling out in this situation after surgery? It's not very well understood. The same for sepsis. This is a meta-regression of different studies assessing the use of procalcitonin in patients with sepsis. You can see the great dispersion we have for different cutoff. And at the end, the median cutoff was 1.1 nanograms per milliliters of procalcitonin as the let's say the ideal cutoff for sepsis. However, using this cutoff, look to the which is how is moving the pre-test probability and the post-test probability. So if you have a pre-test probability of 20, I think it's reasonable to do biomarker here, because you don't have uncertainty if the patient have an infection or not, or sepsis or not, because you guess that the patient have 20% of probability. If the biomarker is below this threshold, you can reduce the probability to 7%, which doesn't mean that the patient do not have sepsis, and probably you have to keep the antibiotics. Again, if the biomarker is above the level of 1.1, then you increase the risk of infection from 20 to 50%. So again, you don't have confirmation of sepsis despite the biomarker is high. And of course, in this case, you have to use antibiotics, despite that then 50% of the cases, the patient is not going to have an infection. Also, biomarkers at the outside of the ICU before the patient is so severe also have another role, which is risk stratification. This is very important because those patients, if we have a good biomarker for that, those patients that have high level of a biomarker, that means that we can stratify this patient as high risk and then have an early ICU admission that is associated with lower mortality than a late ICU admission. So stratifying risk is something that can be also be helpful, not only identifying sepsis, also stratifying the risk. Probably the best biomarker for that is proadrenomedulin. This is one of the studies done also here from one of my colleagues here in Spain, assessing different biomarkers and the area under the curve, which is not fabulous, but it's okay, it's around 0.8. For proamedulin, it's selecting better which patients have a higher risk of death, and probably we have to think in algorithms that those patients with high levels of proadrenomedulin need an early ICU admission. Procalcitonin is not so good in predicting severity. In fact, the risk ratio for mortality in patients with high levels of procalcitonin is 2.6. So it's 2.6 times higher risk of mortality if your patient have a biomarker above the threshold compared to those patients that have the biomarker below the threshold. So it's helping, but it's not helping a lot. It's helping better if there is no clearance, but for that you have to wait to have a second determination. So I think it's not very helpful at the bedside. I think an important message is that maybe you don't have to wait for starting antibiotic therapy if you are convinced that your patient have an infection. Only if your patient has sepsis and septic shock, then a sepsis code, a fast track activation, it makes sense. And for those patients that really have an infection and no sepsis, probably we can wait. Also, another factor that I would like to consider, and we write this with again my colleagues from Spain, with Dr. Mensa. We also are interested in the frailty of patients. So some patients are still not in a situation of sepsis or septic shock, but they are very fragile. We identify, in this case, frailty using Charlson score and also a combination of biomarkers. And if the patient have systemic inflammation, despite do not have organ dysfunction, but is a frail patient, probably also in these patients, we can consider this patient as a potential septic patient. And also we can start therapy before, as a fast track, before the patient progress to deterioration, to septic shock, and refractory septic shock. So, as I said, early recognition is very important to start therapy. The most recent guidelines recommend early antibiotic therapy based in two factors: shock present, shock absent, and uncertainty. So if you are certain that your patient have sepsis, it's not so important if the shock is there or the shock is absent. If you are convinced that you have a patient with infection, then you should start antibiotics immediately, no later than 1 hour. If you have uncertainty and you consider that sepsis is only possible, then if shock is present, again, the panel considered antibiotics should be started as soon as possible before 1 hour. But if the patient have no shock and you have uncertainty about sepsis, then the guidelines consider that you have more time to think about which is the potential diagnosis. So I collect this in this slide that take into account which is the uncertainty and which is the severity. If sepsis or septic shock is there, then you start immediately antibiotics. But if not, then you have to keep your diagnostic workout using X-ray, biomarker, rapid diagnostics test, etc., and only start antibiotics if infection is confirmed, and wait if infection keeps to be uncertain. We keep some uncertainty on that. So with that, thank you for your attention, and I am happy to take all the questions you have regarding early sepsis recognition.